Good morning, welcome. Thank you all for joining. We will start in a second. We're gonna let folks trickle into the Zoom space and then we will get started with our program today. Good morning, thank you for joining. I see somebody already said hello in the chat, so please feel free to use the chat to introduce yourself, say hello, where you're from, your name, and what you do. So my name is Damilola Jolayemi. I am a program coordinator at the Center for HIV Identification, Prevention, and Treatment Services, and also at CBAM, which is the Center for Behavioral and Addiction Medicine. So today we are having our second session in the Case-Based Learning Collaborative on Stimulants Series. And it's hosted by the Center for Behavioral and Addiction Medicine at the UCLA Department of Family Medicine. This series are on the first and third Fridays at 12 p.m. to 1 p.m. So we have a few more that will be happening this year, and then we will start again in the new year. Can I get the next slide, please? So these are the objectives, and for the sake of time, I would not go over them because we've seen them in all of the correspondence that has gone out. Next slide. Just a few Zoom housekeeping items. The format today, we'll ask folks to use the Q&A for questions and the chat for comments during the lecture. So there are two options that you can use. There's a Q&A section for questions, and you can use the chat for comments. For CMEs and certificates of attendance, please attend the entire lecture to be able to request that. There's also closed captioning enabled for folks. So that's an option. You can just kind of click the option that says show captions, but that's already enabled. For past presentations and slides, those are going to be available on the CBAM site, and we'll send that out as an email after the lecture. The next lecture is in 2 weeks on November 17th, and that will be presented by Dr. Brian Hurley, treating stimulant use disorder in primary care. Next slide. All right, so we're going to have a quick poll today. So if you look on your screen, a poll is going to pop up. It's just a pre-quiz, and I will read it out as well. All right, so what is considered the gold standard behavioral treatment for stimulant use disorders? So the first option is cognitive behavioral therapy. The second is motivational interviewing. And the third is contingency management. And the fourth option is there is none. So what do you think that is? You can go ahead and just answer that question on the poll. The second question is contingency management has been shown to A, increase rates of negative stimulant urine drug test, B, increase adherence to PrEP, C, decrease rates of new STI infections, including gonorrhea, I guess, the syphilis and HIV, D, awareness of risk associated with chemsex, E, all of the above. The last poll question is just to share what title best describes you. So if you have enough time, you can answer those questions, and we'll go to the answers right now. All right, next slide. So if you answered C for number 1, you were correct. If you answered E for number 2, you were correct. All right, so we are at the 4 minute after the hour. I'm going to go ahead and hand this over to our moderator for today, who will introduce our speaker. Our moderator is Dr. Julio Meza, who is the Addiction Medicine Fellowship Program Director in the Department of Family Medicine at UCLA. Dr. Meza, go ahead and take it over.
Okay. Thank you very much, and good afternoon, everyone. Really exciting that we kicked off this project and these presentations last week, and it's amazing for me to see how the number of participants continue to go up as today we're introducing ourselves and everything. Today, I have the pleasure to have Dr. Jesse Clark to be the one who provides pretty much really new information when it comes to the treatment of methamphetamine and stimulant use disorder, but with more than just the aspect of the pharmacology and the condition itself of a stimulant use disorder. So Dr. Jesse Clark is a professor in the Department of Medicine, the Division of Infectious Diseases, and also the Department of Family Medicine here at UCLA Geffen School of Medicine. He definitely has a breadth of experience in research. Definitely he has had a lot of research in HIV, STIs, and substance use as well among men who have sex with men. and trans women as well, not just in the US, but also in Latin America. In Lima, Peru, Dr. Clark worked as explorer, and he explored the application of new diagnosis and prevention technologies to the social and sexual networks of MSM and trans women as a tool to integrate HIV and STI prevention as well. He included as well studies for partner notification and treatment as well. So definitely we have a more comprehensive approach to this patient population. Right now, he has become as well the director of the UCLA Vine Street Clinic, where he is leading with several studies for HIV prevention and also HIV treatment, HIV trials network as well, and the NIDA clinical trials network. So without further ado, I want to introduce Dr. Clark, who is going to provide us the guidance in this conversation today. Thank you, Dr. Clark.
Hey, thank you, Dr. Mesa. It's a pleasure to speak with everybody today. Thank you all for coming. So today, this title has changed a little bit since we first started. It's really going to focus more on HIV and meth among men who have sex with men, with a little bit about STIs. And we're not going to talk that much about gender minorities, trans women or trans men, or gender non-binary individuals, because they are a different population. There's just not enough time to talk about all these people. Can we have the next slide? So there's an overview of the talk. We're going to talk about the epidemiology of meth use and its association with HIV and STIs, talk about chemsex as a public health problem, and then go into practical approaches for harm reduction for both stimulant use and HIV and STI prevention, covering medical management, behavioral therapy, and future directions for treatment and prevention. Next slide, please. Who am I? Dr. Mesa just told you I'm a professor in the Department of Medicine, Department of Family Medicine, medical director at the Vine Street Clinic. I do research on HIV and STIs among sexual and gender minorities in the US and Latin America. Next slide, please. So the epidemiology of meth use. The prevalence of amphetamine use has been estimated as 0.7% of the total population, with 11% of people meeting the criteria for dependence. In the National Survey on Drug Use and Health, and NSUDH, 0.7% of all respondents and 2.3% of gay and lesbian participants in the 2018 survey said that they've used meth in the past year. And meth use has increased rapidly over the past decade, with 1% of adults in California reporting use during the past year, and 20% of MSM between the ages of 15 to 22 reporting use over the past few months. Back in 1994 to 1998, which may seem like ancient history now, 32% of MSM in Los Angeles reported using meth in the previous 6 months. Next slide, please. This and the next several slides are all drawn from the LA County Health Department's SAPSI data brief from July 2022. But here you can see the 196% increase in meth-associated hospitalizations over the decade from 2010 to 2020, accompanied by a 264% rise in meth-associated ER visits. Next slide. And you can also see a dramatic increase in meth-associated overdose deaths, with drug overdoses associated with meth use increasing by 1,185% during that 10-year time frame. Next slide. And you can also see the racial disparities. So it primarily affects Latino and African American communities. You may say that there's a lot of Latinos in LA. This is not very surprising, but when you look at the representation per population, there's 208 per 100,000 Latino individuals and 223 African American. So you can see a radical overrepresentation of these groups among the people reporting meth use as a problem. Next slide, please. And they're associated with STIs. So the frequency of STIs diagnosed among people who are admitted for an encounter related to meth use is much higher than people who are not. So chlamydia, gonorrhea, syphilis, and herpes are all higher among meth users than non-users. Next slide. And then this is a pattern of sexualized drug use. So you can see 63% of these people with a primary meth problem reported meth use either before or during sex during that 2021 time period. Next slide. So it brings us to our primary case. In primary care practice, your patient is Julio. He's a 31-year-old cis male Latino film producer, comes in for a routine physical exam. On medical history, he discussed the fact that he's HIV positive, diagnosed in 2016, currently on Biktarvy. He thinks his viral load is usually fine, but when you look back at his records, you can find that he's often viremic with a viral load of 15,000 at his last visit. He has a history of multiple STIs. He's been diagnosed with rectal gonorrhea 3 times, urethral gonorrhea once, and pharyngeal gonorrhea and chlamydia twice. And he's a herpes simplex virus 2 genital herpes positive. His blood pressure is borderline hypertension. His measurements have been consistently 140/85 over the past 2 years, but he hasn't started medication. In terms of social history, he lives in West Hollywood with his husband, Max, who's HIV negative and currently on PrEP, and their Labrador, whose name is Chloe. They have multiple sexual partners. He hooks up approximately 5 to 10 times a week. The frequency is highly variable, though. It's very connected with his socialization and what he does on the weekend. Usually meets up partners through hookup apps like Grindr or sex parties. All of his partners are cis male. He engages in both oral and anal sex with versatile role, both top and bottom. HIV status usually not discussed with his partners. He doesn't know their HIV status either. And he doesn't use condoms with any of his partners. Just doesn't even think about it. Next slide. Continuing with social history, he drinks alcohol. When you ask how often he drinks to get drunk, he says pretty much every weekend. He does smoke socially when he goes out to bars on weekends. His meth use was initially recreational, only on weekends as well, together with his husband at first. Now it's daily with or without his husband. It's only oral. He's never injected, but there has been an increasing frequency of use, and he finds he's been developing tolerance that he needs to get more meth to get the same high over the past few months. And he says it's gotten to the point where he really can't have sex without using meth. The two are inextricably linked for him. And he's concerned because it's causing problems with his work. He's had some errors and missteps, and he's been threatened with the loss of his job if he keeps it up. And he's had some problems with his personal relationships. Other than Max, members of his family have told him that he needs to stop, and he's at risk of damaging his relationships with them. So he really looks you in the eye and says, I need to stop. This is going to ruin my life. Please help me do something. Next slide. And then on physical exam, you find this maculopapular rash on the palms of his hands, which is pretty much diagnostic of secondary syphilis infection. Next slide. Okay, so this is a good platform for us to discuss what is chemsex. So chemsex is not just the additive relationship of sex and drug use, but it's a much more complex interplay of sexualized drug use. And it also has synergistic effects on HIV and STI risk. One of the definitions of chemsex is substance use to enhance, prolong, or facilitate high-risk sexual behavior among MSM. Some of the reasons why people engage in chemsex: it increases your pleasure, hedonism, also pleasure-seeking behavior. This is accentuated or assisted by the fact that people have lowered sexual inhibitions, and frequently people have enhanced body image. So especially among gay men who may have body image issues, when using meth, they don't really have that. They're not worried about looking hot enough. And so it helps them to engage in sex with more people more readily and more happily. It allows them to get extended periods of prolonged sexual activity, and frequently get to the point where Hulu is, where people can't dissociate sex from substance use. The two are tied together, and you can't think of one without the other. And as a result, chemsex needs a similarly sophisticated and complex response. We can't just treat it as an additive drugs plus sex response of addressing drug use and addressing sexual risk behavior. We have to address the behavioral and pharmacological therapies, along with the modification of the social context of chemsex. We really need a comprehensive approach to addressing chemsex as a risk factor for multiple problems. Next slide. So this is a diagram I came up with. It's not definitive, but some of the different behavioral, social, and biological factors associated with meth use that increase risk for HIV acquisition and transmission within their community, within their sexual network. So when people use meth, as we just discussed, they're more likely to have high-risk sexual behavior more frequently. They also have increased risk for depression and anxiety. There's an erosion of interpersonal commitment and social responsibility within their communities, which increase the likelihood of engaging in risk behavior and lack of concern for acquiring HIV or transmitting sexual partners if they're already positive. There's also a higher incidence of bacterial STIs. These STIs increase viral load and increase mucosal inflammation, also increasing the risk of HIV and STI secondary transmission. People who are using meth more often engage in high HIV STI prevalence networks. They're more likely to be exposed to an STI or to HIV during condomless sex because of this prevalence within their networks. And they also have issues with adherence to PrEP and ART, which increase their viral load, which increase the risk for HIV acquisition and transmission. And these problems occur in the nexus. So next slide. Okay, so let's talk about pharmacologic therapy. In preparation for this talk, as well as trying to get some MOC credits for my deadline, which was at the end of this year, I was doing a lot of searches on UpToDate recently. And so one of the searches I did was on stimulant use treatment. One of the first statements they make in today's entry is that only psychosocial interventions have demonstrated efficacy in reducing stimulant use in patients with stimulant use disorder. Stared at that for a while and scratched my head, and still don't understand why they would say that in something that's called up to date, which is not reflecting the current findings. But as Dr. Shoptaw talked about last week, and we'll talk a little bit more now, there are actually medical therapies, some of which have been well established in phase 3 trials to be effective in reducing methamphetamine use, including naltrexone bupropion combination, which was used in the ADAPT-2 trial, and mirtazapine, which has been used in several phase 2B clinical trials recently. Next slide. This is a diagram for the ADAPT-2 trial showing the overall 11% treatment effect. This trial was very complicated in the way that it was designed. So people were assigned to treatment or placebo arms at the beginning, and then there was an interim evaluation, and people who were in the placebo arm could be then reassigned to the treatment arm, depending on their lack of response to treatment at that point. But given this complex design, they did see an overall 11% design, and you can see the curves here where they're looking at the percentage of negative urine samples for methamphetamine among people in the placebo arm, which is the lower curve, and the intervention arm, which is higher, and showing a substantial reduction. So really should be a staple of pharmacologic therapy for stimulant use disorder, naltrexone bupropion, especially for methamphetamine. The next slide. And interesting, Jeremy Kidd did a subgroup analysis post hoc of the data and found that the benefits of treatment were greater among men who reported sex with other men and or women than among men who reported sex only with women, cis women. There was a similar frequency of chemsex between the two groups. Both reported using meth on about 33%, engaging in sex on 33% of their meth use days. There was a similar rate of condomless sex. Nobody was using condoms in any of their encounters. But the men who reported sex with other men also reported a larger number of recent sex partners, so a median of 4 as opposed to 1 among the exclusively heterosexual MSM, and found that the MSM responded better to treatment. So they were more likely to reduce their use in response to the treatment. So this raises a lot of interesting questions. Is there a qualitative difference in the way that the MSM in this cohort were using drugs in relation to sex that made them more receptive to treatment? Was there something about their frequency of use or their patterns of use? Is it that sexualized drug use, which wasn't actually terribly well captured with this data, is more common among MSM and a more frequent motivator for use, so that it's something that they would respond better to treatment, as opposed to people who are not using it for sexualized drug use, but instead using it for things like to stay awake or to work long shifts or something like that, where they may not be as easily able to stop or may have developed more of a tolerance and not use as recreationally. Don't know. There's a lot of questions still to be answered from this, but it's a very intriguing finding from this trial. Next slide. So this is some of the data on mirtazapine. Most of it has come from Phil Coffin and Grant Colfax in San Francisco. As I said, they've done 2 phase 2B clinical trials of mirtazapine, and they're gearing up to do a larger phase 3 trial of mirtazapine for meth use disorder. In the latest trial, there was 115 MSM and 5 trans women, and there was a significant effect in terms of the number of positive urine test results for methamphetamine that was seen among people assigned to receive treatment versus placebo, and you can see that in the curves on the left. Also, interestingly, people in the mirtazapine arm reported significantly fewer sexual partners, significantly less serodiscordant sex, so sex with a partner who is a different serostatus from them, either positive or negative, and fewer episodes of condomless receptive anal intercourse with serodiscordant partners, which is considered one of the highest risk activities for HIV transmission, than people who are in the placebo arm. Next slide. So with this information in mind, you come back to Julio and you discuss these findings. He says he would like to start medication, doesn't like needles, really does not want this naltrexone injection, especially after you just gave him this big shot of penicillin in his butt, which was really painful. So you agree that he'll start mirtazapine nightly. You also refer him to an outpatient facility so he can start behavioral treatment. You don't have anything available in your clinic at that time, so you give him a referral to outside. And you plan to follow him up in 1 month to see how things are going then. Next slide, please. So he comes back in a month and he brings his husband Max this time. Julio started on mirtazapine, but the referral hasn't really happened, so he hasn't started behavioral treatment yet. He reports a moderate decrease in his meth use after starting the mirtazapine, as well as a moderate decrease in his sexual activity, as well as a decrease in his cravings for meth use over the past month. Well, he's still using several days a week, often in conjunction with sex. At this visit, he says, you discuss again his elevated viral load. He says, yeah, I've been having trouble remembering to take my Biktarvy sometimes. You ask how many doses he missed, and he says, okay, we're being honest. I trust you. 3 to 4 days a week on average. Okay, that's bad. But thank you for telling me. And then since Max is there, he's on PrEP, but he says he's been similarly been having trouble remembering to take PrEP, usually because of his meth use. And actually last week he had a positive HIV test for the first time. And now he comes in because he would like to start ART as well. Next slide. So let's talk about behavioral therapies. Contingency management, cognitive behavioral therapy, and affect regulation have all been used as treatment for methamphetamine use disorder. Next slide. Contingency management is really the only proven effective behavioral therapy for meth use, and according to UpToDate, the only psychosocial intervention that's effective, or the only intervention that's effective. It can consistently reduce stimulant use among treatment-seeking individuals. That's an important caveat. What is contingency management? Well, it's provision of an escalating series of small, frequent rewards in exchange for sustained abstinence, in this case from methamphetamine, confirmed by negative urine drug screens at regular visits, either 2 or 3 times a week. It works because these small, frequent rewards provide a form of a substitute for the immediate gratification of meth use and address the problem of delayed discounting, which is common in substance use. Delayed discounting refers to the people's preference for an immediate reward over a larger reward further down the line. So when you say to somebody, you can either take a hit of meth now, or I can give you $1,000 in a week. Most substance users would say, I'll take the hit of meth now because the delay just isn't worth it. Or more accurately, I can give you $100 now or $500 in a week. And people who engage in delayed discounting would say, I'll take the $100 now rather than waiting a week and getting a much larger sum of money. With contingency management, the goal is to have sustained reductions in use or abstinence, which will support operant conditioning in the brain, allowing for transformation of behavioral patterns, basically making it a routine so that people, after experiencing these small, frequent rewards that help them cut down or decrease their use, you're creating new patterns of behavior so that they don't resume their previous patterns of use or abuse. Next slide. So there have been a lot of studies of contingency management at UCLA among Dr. Shoptaw and his colleagues. This is one of the earliest studies on the left showing patterns of methamphetamine use during the course of a 12-week intervention where people assigned to contingency management had much like higher frequency of having a negative urine drug sample during the intervention. And then Rick Ross's paper from 2002, comparing contingency management with cognitive behavioral therapy, or contingency management and cognitive behavioral therapy together. And you see that contingency management, either alone or with CBT, shows consistent benefits in reducing methamphetamine use in this population. Next slide. And this is from Dr. Shoptaw's paper from one of his first contingency management studies published back in 2005. Again, comparing contingency management with CBT or CBT plus contingency management together, or a new gay-specific CBT that he developed, I think, with Kathy Reback at that time. And again, contingency management, either alone or in combination, did show the greatest benefit in terms of reducing meth use as measured by % of negative urine drug screen samples. Next slide. And this, Dr. Shoptaw and Dr. Reback did a follow-up study. Comparing, again, CBT with contingency management and seeing the consistent benefits that you get, not just from the original study, but also from a replication study. As Dr. Shoptaw said last week, one of the hardest things to do in research is the same thing twice. And the fact that they've replicated the benefits of contingency management in multiple studies really it closes the book on the question of whether it's an effective intervention. It's an effective intervention. It's just a question of figuring out how best to use it. Next slide. And so a sub-analysis that was done by Kimberly Ling Murtaugh and Kamaz Krishnamurthy looked at people who saved versus spent their rewards. So this is looking at the issue of delayed discounting and saving up. So they found that people in the trial were given vouchers that they could cash in for rewards whenever they chose. And so they compared the people who cashed in their vouchers to get frequent small purchases compared to the people who were saving their vouchers up to get a really big reward. You know, they want to buy a TV or something, as opposed to the people who use their vouchers to buy a pack of cigarettes or, you know, some gum or something like that regularly. And they found that actually the people who cashed in their rewards frequently had a much better response than those people who were saving up their rewards for a big ticket item, suggesting that, you know, it's a critical component of the benefit of contingency management, this frequent spending, the frequent small rewards, that if people try to save it up and wait to get a big reward down the line, they're less likely to be successful than the people who are getting these small positive bursts of support along the way by cashing in the rewards for little things here and there. Next slide. And this studies that Dr. Shoptaw did with Dr. Landovitz and Dr. Reback, they were looking at, so this is looking at a non-contingent yoked control comparison arm. So the non-contingent yoked control basically means that they took people randomly assigned them to get either contingency management, and in the control arm, instead of giving them nothing, what they did this time was to give them the full amount of the rewards that they would get from the contingency management. So if they could get up to $500 in rewards through contingency management, they just gave the people $500 in rewards, whereas people in contingency management arm were subject to the testing and the incentives distribution. The goal of this is to see is it just giving people money that's the benefit, or is there something about the way that the distribution of rewards is structured that is the key? And it looks like the latter. So people who are in the non-contingent yoke control, who just gave this bolus of money with no strings attached, did not do as well in terms of controlling their meth use as the people who were in the contingency management arm. And you can see the significant differences there with the greater response among people who were getting the rewards on a contingency management basis. They also saw patterns of use were different. So they created these 4 different classes of users on the right, or responders to the intervention, either people who responded and had consistently negative urine drug screens, people who had a single positive urine drug screen, or people who had worsening response with multiple positive urine drug screens, or non-responders who never had a single negative urine drug screen. And so most people were in the non-responder or worsening group, but you can see among people in the contingency management group, there's greater weight among people in the responder or single positive group, and whereas in the non-contingent yoke control, there much more people fell into the worsening or non-responder groups. So the overall pattern of use was different between the 2 different groups. Next slide. And this is what Dr. Shoptaw and I refer to as his white whale. Tim Mensa's study, which was done in an STI clinic in Seattle, where they basically took all comers, all MSM using meth, and enrolled them in a contingency management trial to see if under real world circumstances, contingency management would be effective. And unfortunately, it was not. And since then, this study has been used as a cudgel to beat Dr. Shoptaw, myself, and anybody else trying to do research on contingency management, because people say, see, it just doesn't work in real world circumstances. You can see at week 12, there was no significant difference in urine drug screens for methamphetamine in the intervention versus control arms. In fact, it seems like it gets worse as time goes along. But next slide, there's reasons for this. The trial enrolled all comers, so people didn't have to want to stop using meth, which seems to be a critical component of success, that people need to want to stop, or at least reduce their use. If you just take somebody who's using meth, enroll them in a trial, expect it to have a benefit, it won't. There needs to be some will to cut back on use there that you're supplementing rather than trying to supplant altogether. The patterns of attendance as well as meth-free urine samples reflected general lack of engagement with contingency management, probably because these people didn't really want to stop in the first place. So you can see only 37% of scheduled visits were actually attended. And you can look among the total number of possible visits with negative urine samples is a very low number. So basically people just weren't coming in for the contingency management visits. And like I said, they just weren't interested in changing the behavior. And so it's very difficult to make a change if if the patient or the participant is not interested. But you can see that there was a small subgroup of participants, those who were likely engaged in care and actually seeking to reduce their use. And this small subgroup more frequently attended visits and more frequently provided clean urine during the study. So again, probably if people were engaged in treatment, it was effective. It's just you were trying to sell people something that they weren't buying, and it just didn't work in that circumstance. Next slide. But there's no reason to throw away contingency management altogether. It really just means that we have to figure out better how to use it in real world circumstances. So you saw in some of the previous slides and that among people who were assigned contingency management, not only did they reduce their meth use, but they also had an unplanned indirect benefit that they reduced their high-risk sexual behavior, which was defined as serodiscordant or condomless receptive anal intercourse. So in multiple studies, we've seen now people have a significant reduction in the number of sexual partners and their reported high-risk sexual behaviors, even after the intervention is over. People report this reduction in behavior. So there's lower frequency of oral sex, condom, anal sex with a condom, both insertive and receptive, as well as condomless anal intercourse without a condom, and other acts like fisting, rimming, and public sex, which likely increase risk of HIV acquisition and transmission. Next slide. So contingency management is associated with transformations in both the meanings and the importance of high-risk sexual behavior. So Dr. Reback and Dr. Shoptaw did some qualitative studies to explore this further. They found that sobriety modifies the awareness of risk both to oneself and to others, and that reducing meth use results in a corresponding decrease in the frequency of chemsex. But more importantly, it's not just the frequency, it's also the meanings and the importance that people assign to these activities. So before the intervention, we have quotes from a couple of participants. Paul said, "I had no desire to have unsafe sex without the crystal. But with the crystal, I had unsafe sex all the time. I didn't care." Nathan, who was HIV negative at the time, said, "The first few times I was screwed by a man, I always made sure he had a condom on. Then I noticed I just made sure they didn't come inside me. Now I'm seeing that's what the crystal's doing to me. I'm letting down my guard. I've compromised and I'm seeing myself compromise more and more in situations like that. Recently, I started getting into swallowing cum. The crystal use is breaking my reserves down." But after the intervention, people's behaviors changed, and these are different participants, but the sentiment was similar. Mark said, "I've had anal sex without a condom when sober. I felt like it was wrong. I felt like I knew better than that, and I had to take some responsibility for what I was doing, and I did." Al said, "I wouldn't do that, not disclose my HIV status now. I wouldn't do that sober. I wouldn't have anonymous sex and not tell someone and not ask. And I never used to use condoms. When I'm sober, I tell people. I'm upfront and I discuss it with them right away. By the way, I'm positive. Second or third sentence. I don't even wait." Next slide. So you can see this transformation of attitudes, not just behavior related to sobriety or to decreased meth use. So this is analysis of the patterns of condomless receptive anal intercourse, comparing the contingency management with the CBT or the gay-specific CBT arms. All three arms of this initial contingency management trial, contingency management, CBT, and gay-specific CBT, had reductions in self-reported sexual risk behavior, although the people in the gay CBT arm, again, this is CBT more specifically tailored to gay and bisexual men, and specifically addressing the patterns of sexual risk behavior, so not surprising that they would have a more immediate reduction in sexual risk behavior, though interestingly enough, it was not sustained, that the difference was not sustained, that the other groups met them pretty quickly. Next slide. So then we have to ask a question. If contingency management is clearly the most effective option, then what's the role of cognitive behavioral therapy in behavioral management? From this data that we've just seen, does this support the use of CBT as a behavioral adjunct to help modify sexual behavior in conjunction with contingency management and pharmacological therapy? So yes, this is an example of Dr. Reback and Dr. Shoptaw's intervention called Getting Off, which has been published repeatedly, and then with Rosemary Venegas, they did a modified version of it that can be delivered by lay professionals in a shorter format than was originally developed. So Getting Off, the intervention is associated with significant reductions in sexual behavior, both number of sexual partners, condomless receptive anal intercourse, and condomless insertive anal intercourse among people who received the intervention. And again, it's been replicated in multiple different studies, and the format has been modified to make it easier to deliver in community settings. So this is something that really could be a basis for routine treatment to reduce risk behavior with people using meth. Next slide. The model is a theory-based intervention to help meth using MSM identify and manage their triggers to use. So the core elements you can see in the figure there: treatment and recovery structure, meanings of meth use, triggers to use, social networks and context of use, emotions and feelings, sex and HIV, sexual identity, relapse prevention, recognizing that people are likely to relapse during the course of treatment and how to manage it when they do, and then behavioral assessments. It's associated with reductions in meth use and high-risk sexual behavior, and promoting HIV prevention activities as well. Next slide. Another behavioral intervention that's been used primarily by Adam Carrico is affect regulation. The goal of this is to target the psychosocial comorbidities that are often seen in meth-using MSM, with the goal of promoting positive affect as a strategy to sensitize recipients to alternative or non-drug related sources of reward and encourage engagement in therapy. So similar to contingency management, you're providing substitute pleasurable rewards that will substitute for meth use, ideally, and give people an alternative to drug use to get the positive feelings that they want. So this in that figure, you can see the skills that are targeted with positive affect intervention: noticing and capitalizing on positive events, gratitude, mindfulness, positive reappraisal, strengths and attainable goals, and altruism. Next slide. So Dr. Carrico has done this in several trials. One of the biggest one is the Artemis trial. So they took participants who were already in a contingency management intervention and used positive affect regulation as an adjunct on top of that to see if it had further benefits in terms of reducing meth use. Participants were randomly assigned to either the affect regulation or an attention control. Both groups, though, did receive contingency management as a baseline. And they found there was a significant improvement in positive affect. There was reduced meth cravings, and depending on how you measure it, there may have been reduced meth use. You can see at the bottom that there's a group by time analysis where there was an overall reduction in the number of meth positive urine samples that were seen over time. However, if you look more carefully at the week by week analyses, you'll find that there was actually no significant difference in terms of, that's the bottom line of this, the first figure there. You can see total number of negative samples during contingency management. There was no difference between the intervention and control groups. But they both did have significant reductions from contingency management. Next slide, please. Okay, so in our case, Julio considers enrolling in a contingency management program that's run by LA County Health Department. That'll be much better than the referral you gave him before, which fell through. But as you're talking now and you talk more about it, viral load, he says he's been forgetting to take his ART, his Biktarvy. He misses 3 to 4 days a week, and asks you about long-acting injectable therapy like Cabenuva. He's seen these commercials of people biking through the south of France and living their best lives because they started Cabenuva, and he wants to be one of those people. As we talked about before, his partner Max had trouble remembering to take PrEP and converted last week. He's seeking to start ART now. And this new diagnosis caused both of them to think about their meth use and how it impacted their medication adherence, both Max initially to PrEP and Julio to ART. Next slide. So they ask you, what do you recommend? And you say, well, we're working on a study right now, actually. We did a pilot study called CMAX, which seeks to integrate substance use harm reduction with HIV prevention using a contingency management platform. So the goal was to both reduce meth use and improve adherence to PrEP or ART among HIV positive and HIV negative MSM who are using meth regularly. In this trial, we enrolled people who were not treatment seeking, similar to the Menza trial. This was for ethical reasons because it was a brief study and we weren't planning to provide care or enroll people in care afterwards. So we only wanted to take people who were not looking to stop their use. But they had to be either on ART with a tenofovir-based regimen or on PrEP with a tenofovir-based regimen, so we could check for the presence or absence of tenofovir in their urine at either biweekly or tri-weekly monitoring visits. And in this study, we randomly assigned people to be monitored either for methamphetamine use or for ART PrEP use, with the rewards yoked to one of those two things, to either having negative urine samples that were negative for meth or positive for tenofovir. Among people assigned to monitoring for tenofovir, there were significant improvements for their ART PrEP adherence. You can see in the columns on the right. And among people assigned to the meth use arm, even though they weren't seeking to stop treatment, there were significant reductions in their meth use as well, as documented by urine drug screen. And this was all published by Sharia Blair last year. So this provides a model for integrating both substance use and HIV prevention through a unified harm reduction platform. So like I was saying about chemsex before, don't treat it as just drug use plus sex. treated as sexualized drug use. And this is the goal of treating meth use not just as an isolated problem, but really as meth use plus HIV prevention all in one. Next slide, please. Okay, so they both decide to enroll in the CMAX program. They come back three months later. The program is ended after 2 months, and 1 month later, they say they've both reduced their frequency of use, although they haven't achieved complete abstinence yet. They both improved ART adherence with an undetectable viral load on their recent testing. And they're satisfied with their efforts to stop the spread of HIV in their community by taking care of themselves and their partners and reducing the risk of HIV transmission. They both reduce their number of sexual partners and the frequency of sex, and they're trying, it's hard, but they're trying to routinely disclose their HIV status, as well as tell their partners that they're undetectable. They both because they are undetectable now. They both recognize that their social contexts are strong triggers to substance use, and they're considering how to reorganize their social lives to reduce their motivators for meth use. So, happy story. It's not the end of it. It's going to be a lifelong struggle. They both know that. They know that there's no magic bullet, but they've at least used these interventions to make positive changes and improve their lives. So that's the end of the slides that I have. There's a lot of elements in these cases that I have not discussed. So if anybody wants to go back and discuss some of these issues, we can happily do that. I can also turn it over to the Dr. Wang and Dr. Gio Cruz for your discussion.
Great. Thank you so much, Dr. Clark. I think maybe I'll recommend some of my first thoughts is that you've sold me on contingency management. If I want to start this in my clinic, and I'm thinking not just our addiction medicine clinic, but our primary care clinics, our HIV clinics, how do I do that? Where do I start? And then if people are already doing this in the community, I'd love to hear some feedback on how that's going.
Yeah, I think there's probably people on the call who can tell us better about how it's being applied in the community. LA County has recently implemented a contingency management program for this specific reason. And we're still in the research stage. I think, like I said, this Mensa study has become a white whale that we can't kill because people are hesitant to use contingency management as a response because they say it doesn't work under real world circumstances. And so it's an uphill battle getting these programs approved. But yeah, I would love to hear if there's anybody on the call who has experienced themselves implementing contingency management in the community about your experiences with this. So there's a question here, what type of incentives are offered? Typically, the incentives are small monetary rewards. So we usually give an escalating series of cash. So previous studies have used vouchers that can be turned in for rewards at a store. Some people use even rewards that range from things like a warm hug to $50 in cash. So it really varies. But in the studies that we do, typically the rewards are structured as starting off with something small like $3 to $5 for their first negative urine screen. If they keep it up for 2 weeks, it goes up to $10. If they keep it up for 3 weeks, it goes up to $15 per screen, and so on and so forth. So we usually just use money, but a small amount of money. And another one of the criticisms is that it's expensive, and you're giving out all this money is expensive, but it's really not. And when you look at the amount of cash expended versus the costs of untreated meth use and addiction, it's really minuscule, the amount of money that we're spending on incentives as the costs of treatment and public health costs of untreated substance use. And so somebody else asked if our agency is not yet doing it, are there studies still happening to direct individuals to that might benefit? So we are trying to get a study funded to do this. Again, the reviewers point to Mensa's study and say we shouldn't do it because it didn't work. But we're trying to get that funded. I don't have more information about the county's contingency management program. I don't know if anybody else, Jen or Dami, if you know more about how people can get referred to that program.
I don't. I know we're evaluating one program that's just getting started, so it's still pretty early. And it's that one specifically in an existing housing program within LA County.
So yeah, and this is honestly a problem I come up with a lot. A lot of people come to me. They've stopped now because the answer has always been no, but I was getting at least once or twice a month people saying, I have a patient who wants to stop their meth use. They have no options. Do you have something going on? Just because it's such a common problem and there's really very little resources available to help people. My recommendation is always, you need to have a comprehensive holistic approach. So don't just throw some mirtazapine at the person. You really need to have it in the context of behavioral therapy, psychosocial support, and like I was saying, ultimately changing the context of use. Because as we know, when people, even if they're successful in achieving abstinence, when they go back to their usual social context, the triggers are all there and people relapse very quickly. Oh, great. Dr. Mesa has a link for approved contingency management providers in Los Angeles. Thank you. I didn't know that existed.
Yeah, exactly. There is about 11 sites that are fully approved right now to provide contingency management across Los Angeles. So it's a really good way to start. And I see as well that someone shared something from the DMC ODS as well, definitely.
Excellent. Thank you. And there's also a question about small incentives like chocolate for contingency management. Yes, absolutely. That's another example of a good. It doesn't take much. It's really surprising how small these rewards can be to actually engage people in the program and at least get them started with contingency management. It's this small burst of positive affect really makes a tremendous difference in helping people curb their use. The question, their slide regarding spenders versus savers is interesting. Are there any specific incentives that can facilitate the former? Well, yes, and that's, I think, part of why we don't use the voucher and store program. We just give people the cash because that's, you're giving them the cash. They like that. That's the burst of positive affect. With the voucher store, they really had to make the decision to spend their money. And there's very interesting research, Dr. Krishnamurti and her partner, whose name I'm blanking on, really did some interesting analyses looking at how people spent their incentives, whether people used it for basic functional needs, like, some money to pay the electric bill, or if they did it for more hedonistic goals, like, buying a case of soda or something like that, and the different ways that people use these vouchers. But like I said, for us, cash is king. And we really, our participants really prefer the money. And so it's easier for them if we just flat out give it like that. And so another question, if we create a program, what's the time frame for having folks in the program for strategizing and stretching resources? So that's one of the key questions and something we're trying to look at now is this sustainable over a long period of time? Once you finish the intervention, typically these interventions will go on for about 8 weeks or 8 to 12 weeks and then stop. And then what happens after that and how do you sustain it over time? So we talked about the fact that the goal is to have this operant conditioning where you're changing patterns of behavior. But we're, one of the things we're looking at in the research we've proposed is to look at tapering off the intervention. So instead of just going cold turkey after 8 to 12 weeks, to gradually reduce the frequency of visits from twice a week to once a week to once every 2 weeks and so on, so that you're not cutting people off completely, but gradually lowering their involvement in the trial and seeing if that has a benefit for sustaining the benefits over time.
I see another question here. If we create a program, what's a time frame for having folks in the program?
Yeah, so usually 8 to 12 weeks. But then the question is, what happens after that stops? Is there a big drop off in the effect, or do you need to continue less frequent check-ins over a period of time? Can you have modified check-ins? All these are questions we're trying to figure out to answer.
Yeah, definitely see these other one. Various countries have been far ahead on the of the curve with harm reduction interventions compared to us, such as Australia. Do we need more research? Any countries that you think that we can emulate from the standpoint of harm reduction strategies and even contingency management as well?
Yeah, absolutely. I mean, yeah, I think Australia is really far ahead of us in terms of research and specifically public health programming for substance use. And I think we can learn a lot from them. There are still questions to be answered, and that's why we're still doing research specifically about how, the questions I'm trying to answer now is how to use contingency management to address chemsex as a specific phenomenon. But yeah, there's really no reason to reinvent the wheel on certain things, except, when I work in international health, there are frequently objections to using something that's been developed somewhere else by, people saying, well, it needs to be shown effective in our population here before we can make it a program. So there is that hurdle, but it's kind of a stupid objection.
Yeah.
There's an
Thank you.
answer in the, sorry. There's an answer in the Q&A. It's interesting. It looks like Joanna Berga at the Venice Family Clinic HIV clinic uses a similar voucher system, but specifically for HIV, which I think is awesome. I guess one of the technicalities I'm thinking about is if we're using contingency management to track like methamphetamine use, obviously we're using point of care right there, like UDIPs for urine toxins, which are not perfect. And then I'm wondering what they're using also for like HIV adherence, if they're tracking, like, is it ART levels? Is it viral load? Can we talk a little bit about some of those like mechanics and what tools are most useful for that? We probably want rapid response.
Yeah, for contingency management work, you really need the point of care testing. And so that's why we were so happy when Monica Gandhi at UCSF came up with this urine assay to detect tenofovir in urine. So we're able to say most people getting treatment for HIV or on PrEP are on a tenofovir-based regimen, not all of them, but most. And so if they have tenofovir in their urine, that means this assay is capable of detecting use within the previous 2 to 3 days. Another mechanism Dr. Gandhi developed is testing hair samples that detects use within the previous 60 days. But the urine assay really helps with this point of care issue. So we were able to use it to see if somebody's actually been taking their HIV meds within the previous few days and give them rewards according to that and tie the two together. Before that, really the only options were hair sample testing, which is usually not convenient at point of care, or viral load testing, which takes a few days to get back. And so none of them allow that same immediate response that you get with the point of care urine testing. So that their assay is not, well, I think it is now commercially available if anybody wanted to use it, and we're using it as a basis for our research studies as well.
Yeah, I guess my question is, in the quote unquote like real world, is this something that we can replicate in different clinics, different settings, if HQ,
I think so. If there's a will, there's a way. The county health department has fully supported our efforts at promoting and researching contingency management. They recognize it as effective and a potential cornerstone for the response, and recognize the importance of meth use to the local HIV epidemic as well. So, I think the health department is behind it. It's just a matter of individual clinics or offices implementing it as well, and seeing if this, small investment in resources is feasible, because it has a tremendous bang for your buck in terms of what you get out of it. So just going back a little, there's a question about spenders versus savers, and is there any specific incentives to facilitate the former, or that savers and spenders can reflect different underlying personality types, perhaps not clear, modifying their spending behavior would change meth use? Yeah, it's both. Those are both correct. I think, the analysis that was done was an unplanned post hoc analysis. It just following up on an observation. So it wasn't randomizing people to patterns of spending. Something I wish Dr. Shopta was here because he could talk about it a lot better, but something else they did was to look at the neuroimaging patterns of people who responded to the contingency management treatment versus those who didn't. And they found it on MRI, there's actually structural differences among people who are likely to respond to treatment, or people who responded to treatment than those who did not. They were looking retrospectively. So it looks like, yeah, there are certain things about a person, about your neuroanatomy and the way that your brain works, that predisposes you towards contingency management over others. And one of them is the spending versus saving.
Thank you very much, and a shout out to let me see, Marilyn White Campbell. She actually just shared the link with some documents on a conference in Ontario on how to implement contingency management. So some ideas right there, and it's a pretty interesting presentation. Includes cost per patient, really cool. So thank you very much, Marilyn.
I guess my last question is then staff. Like, so if I wanted to start a contingency management program, who could do this? Is it like just one of my front desk people? Is it an MA? Is it the fellows? Because we have a lot more time. Like what's the time commitment for a clinical setting looking to implement this?
So typically you do need dedicated staff to do it. It doesn't require a lot of specialized training. The way that we implement contingency management, we couple it with motivational interviewing. So each time somebody comes in for one of their screening visits, they have a brief, I'm talking 3 to 5 minutes session with a counselor for motivational interviewing to talk about their goals of reducing use or promoting preparity adherence. And then, to also review the results of their urine at that visit. So it's a few minutes. It does require some training. Usually Dr. Shalpa trains our staff, but it's not, it doesn't require a professional counseling degree or anything like that. It can be done by lay people. It's a brief intervention, only takes a few minutes, and it's pretty easy to implement. Yeah, and as in the chat says, someone detailed with full-time dedication is necessary. Yeah, I mean, probably the fellows, well, maybe you would have time to do it, but we usually rely on MAs and research staff to do that. Oh, and also in terms of the frequency of the visits, something I didn't mention there, one of the things we included in our CMAX study was we randomly assigned people to either 2 or 3 times a week for these monitoring visits, because 3 times a week is better in terms of response, but it's also more demanding. And we actually found 3 times a week was terrible, that people were much less likely to come in that frequently, and that twice a week was about all that we could expect people to do, realistically.
Let's see, looking for more questions here on the chat. I don't see any more. Any other burning questions that you may have, Dr. Cruz, Dr. Wang? If not, definitely we don't want to go beyond our time, definitely. Okay. No? Okay, so maybe Yoli, would you like to
actually
give the
one
last
question that just popped up in the chat.
Oh.
So you can address that before I close up.
Oh, nice. Yeah. So one of the limitations in contingency management when working with HRSA and Ryan White funding is that cash-like reloadable debit cards used in contingency management programs are not allowed. What incentives do you use?
Yeah, that is a problem. We are not HRSA funded, so we do our work through research, so we just give people cash. But yeah, that has been a problem of how to get vouchers funded through Ryan White. Usually I think the solution is to use an alternative funding mechanism for the incentives.
And it seems like everyone is thanking you for a great presentation. Thank you, Dr. Clark.
Thank you, Dr. Mesa. Thank you, Dr. Cruz and Dr. Wang. And thanks, everybody. It's been a pleasure. And thank you, Nami, as well.
Thank you all. Thank you, Dr. Mesa. Thank you, everyone, moderator, our speaker. Thank you all for attending. There will be an evaluation that pops up at the end. Please help with taking the evaluation so we can better, improve our lectures in the future. The next lecture is on November 17th, and that will be at the same time at 12 p.m. And that flyer will go out in an email to folks who registered and have joined our listserv. Thank you all once again, and see you at the next session.